1.5 the diameter, and this is true for all trocars, of course. And what is the issue if you forget it? The issue can be this. The resistance of the skin can last for a while until it finally accepts your pressure, but you will not be able to stop your pressure before the trocar is in a large vessel. And it is mostly true for the first one, because it's in the midline. So these kind of hazards still exist, and take the surgeon immediately to the court, because the issue can be very bad. So, just to remind that behind very sophisticated protocols there are very basic rules which has to be respected. That's why we are here to get experience for the medical team, and also to remind you about the quality of your equipment and the respect of established protocols. Don't try to reinvent the wheel every week. You have also to set your environment at the same level. This is true for your colleagues. The acceptance of the training board, the acceptance of abdominal pressure shouldn't be an internal debate. There is literature about all this, even in the anesthesiology world, and the management of specific complications also should be known by the team. Instruct also your nurse, and don't leave anybody behind, because he can be the source of your problems. And that's why training of all the team is mandatory, whatever the method, with readings, practical courses, pelvic trainers, animal models, as you have experienced this week, and visits. There are no true specific contraindications to laparoscopy, except the environment of congestive heart failure or severe BPCO. There are some specific contraindications, like just mentioned by Eric. In case of important abdominal adhesions, you have to be able to manage them, take another way, like an extraperitoneal route, or be able to manage them laparoscopically. And always inform your patients about all these possible issues, and evaluate the ratio, the cost-benefit ratio in terms of risk of the minimally invasive approach versus a classical approach. So start your experience with easy procedures, be always aware of possible hazards, don't accept excessive operative time, because there you lose the advantage of minimally invasive approach, and respect the procedure, and keep able to convert. It's not a defeat, it's just another way to achieve the same goal. So don't expose your patients to any source of accident. For example, for the creation of the pneumoperitoneum, you may use a Veress needle, but the golden standard in a court will always be the open cilioscopy. There are some alternatives to the Veress needle, and probably the Veress needle is the consumable where you shouldn't compromise the result of the puncture, because reusable material is not ideal in this field, because the spring is the weak part of the chain there, and so use always a new needle to start a new patient. And for what regards the puncture points, you know that the navel is the natural start point above the navel or below the navel, but in case of doubt or in case of problems, think about the upper left quadrant, where probably there is the less chance of having any adhesions. But in any case of doubt, convert to an open laparoscopy, and to place your first trocar, inspect, and then place a second one, release adhesions with the first instruments, and so on. And step by step you can install all your set and start your true procedure. When you have used the blind insufflation, I would say there are also some possible hazards, And if you read an immediate high pressure, you have to suspect that you are below the skin but above the fascia. And if you have gone through the fascia, you can start insufflation, but then the pressure rises again. And this is probably because you are not in a true free space and you have equilibrated quite vastly the pressure, so that here you should probably go for another approach in another quadrant, for example, and as soon as you will insufflate the right space, you will be able to collapse the first one and take the right way again. What can also happen is that you put your needle too far without knowing it, and there is no high pressure. And when you inspect the abdominal cavity, you realize that you have insufflated a loop. This is not a particular problem. Generally, the hole is small and doesn't need a repair. The same for an hematoma of the retroperitoneum, which should be left self-limiting and shouldn't be opened, because in this case it wouldn't be limited, and sometimes the true origin is difficult to find if it's not a very large vessel, of course. So again, the reminder about this possibility of very important vascular emergency, but fortunately we experience other bleedings with smaller vessels. They are more frequent, and they can be managed with a kind of modified Reverdin needle like this, placing a U-stitch along the trocar shaft, or placing a Foley catheter through the trocar and insufflating the balloon to create a pressure by pulling on the Foley and leaving the hole until you have time and access to the opening of the bladder wall, of the abdominal wall, sorry, and be able to dissect until you reach the vessels. And this concerns mainly not only the epigastric but also small muscular branches, which can be in the area of the iliac crest, for example, like the circumflex arteries. To prevent this, again, use the diaphanoscopy, as illustrated already this morning by Eric. This can prevent you to harm small veins under the skin, for example. They are also a source of pollution of your field. And to summarize this, check your equipment and don't go alone. Set your expectations, establish the risk scale, know your itinerary and be prepared to change your itinerary and convert eventually, and eventually hire a proctor or a trainer for your first steps. So to keep in this mountain ride environment, there has been a classification of procedure to start your practice according to the risk you take and the dexterity you need. For the very first procedure with easy access and minor vascular risk, you have the lymph node dissection, actually, which is probably the best procedure. For minor vascular risk and adding the difficulty of a suture, you have the stone disease procedure when replacing the modern way of dealing with stones. You have also the pyeloplasty, and of course the Burch procedure has been completely replaced by the slits. Then you have more difficult procedures like enlarged nephrectomies, partial nephrectomies, nephroureterectomy, and adrenal surgery. And the last ones are the most difficult. We have illustrated the last 2 days: prostatectomy, cystectomy, and eventual retroperitoneal lymphadenectomy, which is also quite demanding technically because of the vicinity with the large vessels. Anyway, we wish you a brilliant route, and keep curious, keep aware of the modern changes, and your way will be bright. Thank you very much.